Arnab Das. He's a consultant at Disha Eye Hospital, Barrackport. As we all know, Disha is a chain of hospitals which caters to a lot of community work. They go to the grassroots and treat patients. And I think they've also made healthcare very affordable for their patients. So he will be talking to us on unmet needs in neovascular AMD.
So let's now hear unmet needs from Arnab Das. Arnab is a very dear colleague doing very great work in Calcutta, Disha. So Arnab, what are the unmet needs in AMD?
Very good evening to my respected seniors and dear friends. Mine is a pretty basic talk, which is basically the unmet medical needs in the management of neovascular AMD. So, sorry. Yeah. Are my slides visible? Yeah. Yes. It's a beautiful world with breathtaking water bodies to behold. But as you know, in neovascular AMD, the water bodies to be noted are the unpleasant ones like the SRF, IRF, and the sub-RP fluid, as Sabhushanshi was talking of, along with the distasteful measurements like the central macular thickness, etc. AMD is definitely a spoiler of quality of life. The impact of AMD on there's one bar which is disturbed. Just a second. Just one second. There's a bar which is disturbing me. Hello. Yeah. There's a bar on top which is disturbing me. It's not going. Sabdasachi?
Where is the bar?
Right on the top.
So उसको ना माइनस उसको थोड़ा ऊपर जाओगे माइनस कर सकते हो.
नहीं उसमें माइनस नहीं है सर, वही चक्कर.
ऊपर जाओगे तो आएगा शायद.
नहीं सर.
Maybe if you press the view, उसको.
Generally, what happens is that when I take my mouse down, it goes away, but this time it is not going.
I know ये साइड वाला कई बार तंग करता है, but वो एक बार माइनस आता है या फिर उसको.
माइनस
या फिर ये जो दूसरा एक एक्सटेंड कर सकते हो आप उसको ना स्क्रीन को horizontally.
Just 1 sec, sir. I'm sorry about this.
We are seeing your slides very clearly.
No, but I can't. Can you see the top bar, the black one, which is showing mute, stop video, and all of that? Is that visible to you, or only I'm seeing that?
No, हमें तो नहीं दिख रहा.
आपको नहीं दिख रहा, पर मेरा कुछ labels वहाँ छुप जा रहे हैं. That's the issue.
But we can see slide very nicely.
Okay. I'll continue. So I'll start. So AMD is definitely a spoiler of quality of life. The impact of AMD on quality of life is very negative. It affects daily tasks like the ones mentioned below. The psychological well-being may be also affected due to visual impairment. Neovascular AMD is a leading cause of total blindness in most developed countries, as you can see here. And you can see that the incidence of AMD increases, the prevalence of AMD increases drastically in both men and women beyond the age of 80, as you can see from these two population cohorts. Aging is the greatest risk factor for developing AMD, so its prevalence and associated socioeconomic burden on the disease is expected to increase significantly as the world population increases. By the end of 2020, nearly 196 million people worldwide were estimated to have AMD, and by 2040, this number is expected to grow to 288 million, that is more than 50% increase. Neovascular AMD, as we all know, accounts for 10% of AMD cases, but results in 80 to 90% of the legal blindness caused by AMD. In this prevalence study about India, which came out from the Shankanethle group, where they defined early AMD as drusen or drusens with RP, hypo or hyperpigmentation, and late AMD as geographical atrophy or neovascular AMD. They found a similar prevalence of late AMD in urban and rural population, but a higher prevalence of early AMD in rural population than urban. Smokeless tobacco and middle socioeconomic status were found to be important risk factors beside age. We certainly know of these treatment option milestones in wet AMD, which has evolved from no treatment to laser treatment and to anti-VEGF therapy, which we have now, and that has obviously revolutionized the wet AMD treatment. And in this interesting article, which was a review of the impact of anti-VEGF on patient outcomes, it was found that the use of anti-VEGF in clinical practice was associated with a significant reduction in the incidence of blindness by neovascular AMD. And between the year 2000 and 2010, there was a 50% reduction in blindness in patients greater than 50 years of age, and a 6-fold improvement noted over 12 months with anti-VEGF injections on the National Eye Institute Visual Function Questionnaire. And Sabrishti spoke at length about these anti-VEGF treatment options, and we of course know the mechanism of action. And prolizumab, as Sabrishti was alluding to, is the newest kid on the block with the lowest molecular weight and the highest molar concentration. We know that the early pivotal trials showed significant visual gains with multi-ranibizumab, and the anchor trial found a greater than 10-liter gain with 0.5 ranibizumab monthly dosing by the end of first year, which was maintained till the end of second year too. As we know, the prevalence of neovascular AMD continues to rise, and to top it, the increase in prevalence is set against costs that are already high, and 0.5 to 0.6% of the total health expenditure of the developed world is already being spent on neovascular AMD treatment. Increasing prevalence coupled with high resource utilization may lead to further difficulties for healthcare systems to manage. In clinical practice, fewer injections are administered than in clinical trials. The real world evidence supports the positive relationship between visual acuity gains and anti-VEGF injection frequency. In this meta-analysis of 26,000 plus patients across 42 real world observational studies reporting outcomes of anti-VEGF treatment for neovascular AMD published between the years 2007 and 2015, you can see from the scatter diagram, which plots the mean change in visual acuity versus the mean number of injection, and it shows visual acuity gains are associated with injection intensity. Less efficacy seen with under treatment. Regions where mean number of injections were higher had greater gains. Due to the treatment burden, clinical trial protocols are difficult to achieve in the real world practice. Long-term visual acuity maintenance in clinical practice is related to treatment intensity. Use of anti-VEGFs in clinical trials maintain visual acuity gains, whereas lower treatment frequencies can lead to visual acuity decreases over time. In this multi-country, real-world observational retrospective study of 2,000 plus patients wet AMD treated with ranibizumab in the year 2009 in various countries, and the countries are mentioned there, it shows that visual acuity improved until about day 120. Thereafter, gains were not maintained. The mean change in visual acuity score from baseline to year 1 and 2 was at plus 2.4 and plus 0.6 letters respectively, and this was of course less than what the pivotal studies had picked up. The patients received 5 and 2.2 injections in the first and second year. Again, this was lower than the number of injections which most clinical trials speak of. There was a substantial difference in the visual outcomes in the and injection frequency between countries. More frequent visits and injections were associated with greater improvements in visual acuity. So anti-VEGF treatment in clinical trial setting demonstrates good efficiency, but the burden in real-world clinical practice limits similar uses. Luminous study, as we all know, is a real-world 5-year prospective multi-center global observation study, and I am quoting from what is came out from this Belgian cohort of wet AMD patients of this 5-year global observational luminous study. The injection frequency declined over time irrespective of prior treatment status, and regression analysis confirmed first-year visual acuity increases for treatment naive cases, followed by a significant decrease of 1.28 letters per year. So after the first year, there was actually a decrease in the number of letters per year. The real-world evidence shows that over 70% of the patients with neovascular AMD are undertreated in the first year of therapy. In the real-world settings, many patients present only after substantial vision loss that limits visual gains. A study which looked into the data of 176 patients of bilateral wet AMD cases from the Fight Retinal Blindness Registry, and this was an Australian study, found that the first eyes generally have large lesions and poorer presenting vision due to delayed diagnosis compared to the second eye, which had smaller lesions and better visual acuity due to prompter diagnosis in the case of the second eye. Thus, 12 months after commencing intravitreal anti-VEGF treatment with ranibizumab, although a greater mean change was observed in the first eyes, their 12-month mean visual acuity was still less than that of the second eye's baseline mean visual acuity. And data from the Luminous study too suggests the same: better the baseline visual acuity, better the mean visual acuity at the end of the first year, with higher injection frequency resulting in better outcomes. Note please, the mean number of injection even in the Luminous study was much lower than the clinical trials. It was 5, and the mean visual acuity gain was just 3.1 letters, which also was lower. So real world evidence shows that not all patients receive full loading doses, impacting the final visual acuity. In the Luminous study, those who missed out on loading doses had a slight drop of 0.4 letters in the mean visual acuity at 12 months compared to baseline mean visual acuity, whereas those who had the loading doses done had an improvement of 3.8 letters. To deal with the treatment burden, physicians have adopted different regimens. However, this can result in reactivation of disease and fluid exacerbation that takes longer to treat. The impact of neovascular AMD on healthcare system is multifactorial, and some of the factors that have led to physicians to explore different regimens for anti-VEGF therapy are shown here. There are unmet needs from the physician's perspective, and in the ASRS preference and trends survey for the members, a question was put up as to what are the greatest unmet needs regarding neovascular AMD treatment, to which some said you need improved efficiency, some said new treatment mechanisms of actions are needed. Good many said longer acting or sustained delivery systems, as Sobhishich was talking of, are needed, but most said reduced treatment burden is the need of the hour. Indeed, monitoring visits are the most time and resource consuming part of patient care with anti-VEGF therapy for individuals with neovascular AMD. Physicians still identify treatment and monitoring burden as key unmet needs in neovascular AMD management despite flexible dosing. The stressed clinic capacity impacts timely treatment. Therefore, adoption of flexible regimens, particularly G10E, to increase individualization and reduce the burden on healthcare resources has gained popularity. However, this may result in delays in detection of recurrences and suboptimal treatment frequency. In the ASRS PAT survey, a question was put up: why do you believe discontinuous anti-VEGF treatment for neovascular AMD is retina specialist's most common regimen? To which few said vision is the same with continuous and discontinuous treatment. Few said physicians prefer fewer shots even if patients lose some vision. Some more said that patients prefer fewer shots even if they lose vision. However, most felt it's a combination of B and C. Thus, in the ASRS PAT survey, many retina specialists believe that discontinuous anti-VEGF treatment is used as a result of physician and patient's preference, even if this results in some vision loss. Patients undergo treatment fatigue with anti-VEGF therapies, and some opt to discontinue treatment. Now, talking about the unmet needs from the patient's perspective, the frequent treatment and monitoring requirements place a heavy burden on the patients. And these are some of the reasons why patients feel that the frequent monitoring is unfeasible, and some reasons why patients discontinue follow-up. The patient's lives are preoccupied by frequent clinic visits. Treatment burden can lead to lack of adherence and persistence or worsening of the problems. In this study, which was basically a 5-year study on adherence to follow-up in real-life settings, it was found that the median time for dropout to follow-up or treatment was 3.7 years. And this was basically a telephonic as well as a questionnaire-based survey. And it was found that distance between the home and hospital, dissatisfaction with treatment, and the need for regular follow-ups, and of course financial burden, were the main reasons for dropout. The rate of loss to follow-up over 5-year period was an alarming 57%. 3 factors were significantly associated with discontinuation in follow-up, namely high age at baseline, poor baseline BCVA, and long distance from home to hospital. To summarize, there is need to build on successes in neovascular AMD care and continually innovate to prevent blindness caused by the disease. Increasing prevalence coupled with high resource utilization may lead to further difficulties for healthcare systems to manage. In clinical practice, fewer injections are administered than in clinical trials. Anti-VEGF treatment resulted in an initial improvement in visual acuity. However, this was not maintained over time. In the real world scenario, physicians have responded to treatment burden in neovascular AMD by exploring different regimens with fewer injections. However, this can result in recurrent disease and permanent vision loss. Patients undergo treatment fatigue with anti-VEGF therapies, and some opt to discontinue treatment. Thank you for your patient listening, and happy Durga Puja from here, from us here in Calcutta, and wishing you happy Dashera in advance.